So the title is a moving target, title of my talk, but it's, and I think I changed it even last night, but it's what's in your booklet with the clips is the right one, and we'll give you the slides at lunch. I do have conflicts of interest. I'm not trying to sell you anything, I promise. And when I get royalties for something that I'm somehow related to, I give it to Have Dreams, which is a wraparound service for kids with autism in Chicago. I also want to say right at the start, because usually I run out of time, that we have to be extremely grateful to the families in these longitudinal studies. In one case, they have stuck with us for over 20 years, and we had one period of time when we were sending them forms every 4 months, trying to see if their kids changed, if they had a seizure before or after the seizure. So these families have been absolute troopers, as have the people with autism who have really grown up with us, watching them and asking them questions and making them fill out forms. And then the various research groups that have supported this effort, including the TEACH program where it all started, University of Chicago where I also had a cohort, and they have been really good even as I've moved to other places, letting me come back. And then a whole group of research coordinators and other faculty and research assistants and students who have spent weeks traveling North Carolina and Chicago and various other places. So what I'm going to do today is talk about a little bit about autism spectrum disorders, or ASD, or autism. I will use those terms interchangeably, so if I switch from one to the other, it doesn't mean anything, just because we're sort of switching gears. And then talk a little bit about the kind of evidence that longitudinal studies can and can't give us, because it is a different approach than clinical trials. And certainly, I think going back to what Anne-Marie said yesterday, many of the things that I will present to you as results of our study would, if we are really going to take them as implications about what to do have to be studied in a more in a randomized controlled trial, if that's possible, and in a more straightforward fashion. So often what we're doing is generating hypotheses. But what we do is we see kids for a long time, and I'm going to talk about 2 prospective studies where we started at one point and then continued on. And we had some specific hypotheses, but have also gathered a lot of information that didn't have anything to do with what we thought we were studying. And that's both has the advantage of not feeding into what you think you're going to find, but also the disadvantage of you always think, I should have done this when he was 2. What was I thinking? I'm going to talk about 2 longitudinal studies. One we did at Michigan, where I worked until 3 years ago. And there we saw a group of kids. It's not a baby siblings project. We asked all kinds of providers and parents that we knew to sort of spread the word that if anyone was concerned about a child who was 15 months old or younger who might have ASD, we would like to see them. And we would try to see them once a month to give them an ADOS, which is this 30 to 45 minute standardized observation, and follow them into early preschool, which meant about age 3. So we have 78 kids in that study. 25 of them actually really didn't have ASD at all, ever. And many of those were siblings where parents were worried, and they were truly worried. But it's a different group than if you study all baby siblings, where families are worried only because their child had autism, the sibling had autism. Here, somebody was worried about something, but it really, actually, as far as we could tell, was not ASD. So I'll talk about that project, and then I'm going to talk about a much bigger project where we followed what started with about 200 kids referred for possible autism, and then a small control group of about 21 kids who had developmental delays, but nobody thought they had autism. Beginning at age 2, we saw them at 2, 3, many at 4, most at 5, 9, 14, 19, and 21. So that's going to be the sort of second half of my talk. And then I'll try to go through what are general implications. And the trade-off with this kind of talk is I have tons and tons of data, which I'm very inclined to show you. But I may, if I run out of time, I may just skip through some of it. I also have videos. And I think for those of you who haven't seen somebody grow up who has autism, I think you'll remember that more than anything I say. So I'm going to try to show you some of those, even though it's not technically data. So as you know, the diagnosis of ASD was reorganized a few years ago in DSM-5 to consist of having deficits in just 2 areas. And the reality is that the criteria are quite similar to what was there before, but they've just been shifted. So what we've tried to do in DSM-5 is take out of the diagnosis of autism, expressive language disorder, and IQ. And that's not because we think it's not important, sorry. It's because we think it's so important. Whether you can talk or not, how well you can understand what people say, whether you have an intellectual disability is just as important as whether you have autism. And we want to be sure that people know that, because that is not, it's independent of autism, but also affects everything that you look at in autism. If you're looking at eye contact, you would expect different eye contact from a child who can't talk yet than from a child who can. A child who can talk, if you call their name, they might say, "What, Mom?" without looking at you, which is not a terrible thing. A child who can't talk has got to look at you. They're not going to hand you something without looking at you, or most kids who don't have autism are not going to do that. So it's pulled out those dimensions. Which are still absolutely important, but are no longer defining autism because they are separate, related, but separate. And then we have 2 areas of deficit. We have marked deficits in basic social communication and social reciprocity. So we have difficulties with things that an ordinary baby can do at about 6 to 9 months. They don't do all the time, but they can look at you, they can vocalize at you, they can move toward you, they can adjust their body around your body. So people with autism, usually across a lifetime, have difficulties in those areas of social development. And in addition, they have difficulties in other areas of social development that do overlap with many other disorders. So they may not share well. They may not look for other people when they're happy. They may not, they have generally a terrible time with peers. They have difficulty making friends and knowing what to do in a group of children. And those things are often not specific to autism at all. They characterize many of the kids that we see with other disorders, but they do affect kids with autism. In addition, there's this whole other area of repetitive behaviors. And we have no idea why these things go together with autism. I mean, there have been simple hypotheses of, well, if you didn't have social skills, you'd be banging your head too. But that isn't really true. I mean, people with autism continue to have repetitive behaviors as they grow older. And then there's this conglomeration of what is in that red circle, which includes sensory things, wanting to smell things that nobody else wants to smell, like plastic things or people's hair, or wanting to flip things on vents, wanting to see things out of the corner of your eye, being overwhelmed by certain sounds that don't bother other people very much. There are also repetitive ways of playing that are not that different from a very young child, but continue on sometimes throughout a lifetime. They're getting stuck on things, subways, anchormen, assistant editors of newspapers, I mean, all kinds of topics, British princes, and there a rigidity and an inability to be flexible. And I just looked last night, I was writing a report, and a child was doing a WIAT, and it says, describe your favorite game. And he described for me one particular soccer game that he had watched. And his interpretation of favorite game, I mean, this is a 7-year-old, instead of like a video game, was a game, one match, which is not bad, it's just odd. It doesn't go over well with other 7-year-olds. So in addition, autism does not protect you from other disorders. And so all of you here who work with ADHD or work with anxiety disorders or work with behavior problems, we need your help because kids with autism have those things too. And they have more of them than other kids. In addition, many kids with autism have language disorders, and many, the numbers going down or the proportions going down, also have intellectual disabilities. And those things affect lives, again, just as much as autism. So the point of view that I'm coming from is that autism is a developmental disorder, and whatever is wrong or different about the brain starts very early. I mean, we start to see it usually in the second year of life, maybe the end of the first year of life. But not only is it there, but then it affects everything else. Because if you're not paying attention to what other people are paying attention to, if facial expressions don't instantly make sense to you, so you have to learn to process them, if you're constantly slightly misinterpreting things or doing things 1 second off, you know, just think about what it's like when you're talking to someone on a phone and you get a second off. I mean, that might be part of what people with autism are experiencing. If you do that, all that information that ordinary kids get isn't available to you. If you've never had a friend, someone who really likes you and really wants to hang out with you, never ever had somebody really, really like that, who will say, cut it out if you're going on, or I think I've heard that story before, then what your experience as a person growing up is very different. Now, I think what's encouraging about that assumption is that we can change so much, because we can with early intervention and with better integrated programs and with better behavior management. We can make a huge difference. We may not be able to make that initial thing go away, but we can change those trajectories that started so early from being so problematic. And I'm going to talk to you a lot about trajectories. Actually, this slide is there just because we have summer day camps, and one of the things we do, half of those girls, 2 of those girls have ASD and 2 don't, is that we put them in confined spaces and they're happy, great things happen. So again, sort of behavior management on the fly of let's put them in a boat and they have to interact with each other. Now, also, just to summarize, in ASD, we have many, many named treatments. We have lots of behavioral interventions and a lot of data that show that these behavioral interventions have some effect. We have parent training programs, some of which are really aimed at behavior management, but some which are aimed more at increasing joint engagement, joint attention. We have environmental manipulation, such as the TEACH program, where we're trying to help kids understand what is happening around them and give them ways to communicate to us their choices. We have things like the peers programs, so social skills programs, some of which have a lot of evidence about minor changes and some of which have very messy evidence, but are very appealing, like RDI and social thinking programs. And then we know that the more parents are involved, the more likely something good is going to happen. And that's true all the way from the tiny kids up through adults. But many of the funding sources, and I see, for example, what's going on in New York with early intervention, fund very little interactions with parents. ABA teams charge in, they set up the ABA programs. Those kids are doing discrete trial, 20 hours a week, in home, because home is supposed to be more natural, and the parents really have no idea what's going on, and have to be there, but don't know and are very much not a part of it. The other frustrating thing is that in terms of treatment outcomes, we can show that early intervention results in significant improvements in expressive language, in nonverbal IQ, and programs that focus on specific behaviors such as joint attention or pointing teach kids those behaviors. We can show that there are significant effects in things like a peers program, so a structured social group, in the degree to which parents organize play dates, and the degree to which parents and kids report that they're more socially competent. But very few programs, and there's really no consistent program that has resulted in a change in diagnosis or even diagnostic features on the whole. Now, some of that is measurement. We don't have ways to measure subtle changes. The ADAS and the diagnostic instruments I've been involved in are really intended to look at diagnosis and bring in wide groups of kids. So they're not the best way to show that a kid has moved from being mildly autistic to a little bit less mildly autistic. They're too clunky. So I think that's something we're working on, a lot of people are working on, but it is something that we haven't talked a lot about in this session. It's just how do you measure changes in things that aren't necessarily going to go away. This isn't a kid who's going to stop having temper tantrums. He might, but he's still going to have autism. We also don't quite know what the role of parents is. Is it direct? That is, we change the parent's behavior, such as in some of the programs we've heard about here, and the child gets better behaved? Or is it indirect, that parents have more confidence, they feel better about themselves, they can make more decisions, they feel less alone, they're more able to tackle having this huge challenge, which is a child who probably is never going to be the child they expected. It doesn't mean the child can't do anything, but is not going to be a typical child. And pretty much we know that if we teach a parent, for example, how to do a better job of setting up a snack so that their child sits still, asks for things, looks at them when they're eating, and doesn't have to have the iPad on, that parent will be able to generalize those skills to getting the child to wash their hands. But we don't necessarily know about how much that generalizes in a broader session. And we just have huge differences in outcome, which I'll show you in a minute. So those are other issues, because the differences in outcome, like people being relatively independent versus quite handicapped or impaired, are not things that we've been able to change. And then one other, I'm just listing all the problems first, you guys, and then I'm going to give you all the answers. One other problem we have is placebo effects, which nobody's talked about here, but RCTs control those. But this is the secretin trials, which probably many of you are too young to know about. But probably, 15 years ago, someone gave their child a pig hormone as part of a radiology test for their GI tract, and they thought that it cured autism. And so it just spread around the world, and people were paying like $800, $2,000 for a shot of this stuff. And so NIH funded randomized controlled trials, and we were part of one. And what we found, and you can see it at the top, in the ADAS, higher is worse. We had families coming out of the woodwork, sensible people that I never would have thought would have hoped that a pig hormone is going to change their child. And families came, and everyone was so excited, and we thought we were seeing changes. So the ADAS went down. The trouble was we were totally blind to who was getting what. And the reality was the ADAS went down for everybody. Not everybody, but it went down the same for placebo, kids who were getting saline solution, as people who were getting the secretin. And that is a huge issue in autism research, because if you're nice to people, little things get better. And I think we should take advantage of that and remember it, because it is real, but it makes it very hard to know if our specific techniques make a big difference. So why on earth would anybody follow a child repeatedly across time? I think the answers are obvious, and that is we want to predict what's ahead. We want to have some sense, even though things are changing all the time, of being able to help families anticipate what's coming up. We want to pick targets for intervention. For example, if we know that almost every child with autism who is pretty strong cognitively is going to stop flapping, or at least learn to flap only when they're by themselves. That isn't such an important target for that child when they're 2 as some other things that aren't necessarily going to get better on their own. We'd like to know when to intervene. Are certain behaviors going to start later, and do they matter, and are they going to go away? And then, partly just out of curiosity, we'd like to understand the relationships between features of ASD. How do the social and repetitive behaviors match up? What are the relationships between those factors and other things like intelligence, aggressive behavior, irritability, activity? And then we ultimately want to come back to the neurobiology, which I'm not going to talk about today, but ask me if you want, because this is a disorder we're not going to make completely go away by behavior change. We need to use the things we know about behavior, but this is something that comes from the brain very early. So I'm going to talk about 2 studies, 2 time frames. And the question is, what doesn't change? What does change? Are changes linear, that is straight up, or are there things that sort of bubble up later? And then what are the mediators of change? And I put this up because this little guy has a placemat. That's what that white paper is. And he wants more snack. And this is part of the old ADOS. We don't have placemats anymore. But he's trying to show that he wants snack when the person who's going to give him the snack is sitting right next to him, but pointing in the other direction. So he's learned a behavior, which is really good. It's just that he's missed out on the fact that she's the controller of the food. So the First Words project was the one with 78 kids. We tried to see the kids as close as possible to once a month. We gave them the toddler ADOS, which is a sequence of about 10 different little activities that the examiner uses in a structured way, videoed this. Mostly it was the same person, the same examiner. We started out randomizing, and it was so horrible for the parents to have every month a different person. Here are parents that are terrified that their kids might have autism, and here's another person. So instead, we had the same person, and every 6 months, someone else would come in and do an assessment. And those people did score the kids slightly worse, I will tell you, about 2 points, so not huge. As you expect, we have more males than females. This is a sample that's mostly Caucasian. And again, for the ADOS total, a typical child on the toddler ADOS would get 2 or 3 points. Everybody does something weird. But 18 is pretty high, and 12 is definitely within the range of ASD. When we started this, we had autism and PDD-NOS. So the other thing I should say is I forced these poor examiners, every time they saw a child, they had to make a guess as to, is this child at age 3 going to have autism? How sure are you? What they did was they said, is this child at age 3 going to have an autism spectrum disorder? How sure are you? And they could be sure yes or no. And then, is this child, if they're going to have an autism spectrum disorder, are they going to have autism? Because in those days, they could have PDD-NOS. They could have Asperger's, but actually being identified at 15 months, they shouldn't have had Asperger's. Also, you should see this is a fairly high-functioning sample. So the mean IQs are about 80, even for the kids who did get autism diagnoses, and 90s for the kids with PDD-NOS, but quite a lot of range. So what these red lines are ADOS scores, and each line is a different child. If you look at the top, the left-hand side are kids who never, even having been seen 15 times, nobody ever said they thought they would have ASD. Okay? So they're really never at ASD. The kids on the right are someone at some point in that 15 times said they thought they might have ASD. Okay. So it doesn't mean they have it, but it means something. And what I want you to see at the top is it's a mess, except that things are very different between the never and the ever, or at least the never and some of the ever. And the gray represents pretty much a standard deviation. It goes wider at the end because there are fewer kids at the end. So we can then statistically analyze what are clusters of trajectories that these kids fall into. So we can take these these lines, each kid has a red line, and say, how do I group these about what's happening to you over time? And then we get data that looks much better. And in fact, you'll see in a minute when I show you the 20-year data, we got data that was different with 4 groups, but still quite different than what we get over 20 years. So we got to a group that was high, and that high again in the ADOS is worse. So they consistently had very high scores, and that's 20% in the upper left-hand corner of the 4. We got a group that got worse from 15 months, which is something we weren't sure we were expecting. People talk about regression in autism, and I'll show you in a minute that probably almost all kids who have ASD regress. And these kids regressed more obviously. So they did get worse over that period, and that's the upper right, another 20%. Then we had a group that got better, which was wonderful to see, and that also was close to 20% in the bottom left-hand corner, so they're going down. They didn't quite make it out of ASD, but they're going down. And then we had those kids that I told you about in the beginning where people never thought they had ASD. Now, those scores are from the ADOS scores. So that's taking the scores, not looking at what the clinicians said. Now, just for a moment of reality check, let me show you what the clinicians did for these same kids. So the clinicians were really good at identifying the kids with severe persistent up in the upper left. And they were good except for one very bouncy child you'll see on the bottom right. They were pretty good at identifying the kids that never had ASD. They were absolutely horrible at identifying kids who were getting better and kids who were getting worse. Now the line for worsening up in the upper right-hand corner is going up. So the average is okay. But if you look at the individual data, the people that knew these kids did not catch subtleties that they themselves had scored on the ADOS. And I think part of it explains why parents' reports of things like regression are so crazy. And people end up interpreting things as if they're very clear that aren't clear at all. Because even skilled clinicians who had just filled out an ADOS still were all over the place of, is this kid getting better or worse? We also did ask parents, this is just parenthetical, if their child was getting worse, because we wanted to note regressions. There was no relationship between what parents said and what we actually saw here. It's just too hard. I mean, and why is it hard? Well, part of it is that during these years, different variables are changing at a different pace in different directions. So here, the blue line is kids who eventually got an autism spectrum disorder. This is the same sample of 78. The white line is kids who never had any kind of disorder that we could see, so typically developing. And the red line are kids who had other problems, which mostly was language delay. Some of them are kids, I wouldn't call a 24-month-old a kid with ADHD, but they're sort of pre-ADHD kids. Something's up. So you'll see that, in fact, the kids with ASD, over time, this is the same kids over time, actually got worse in eye contact from 15 months to about 2.5. They actually got better at joint attention, which is not surprising. They never quite got up to where the typical kids were. And again, remember, these are smart kids. So these are not mostly kids with ASD and a developmental disability. So they're getting, I should say we flipped these. So going up in this case is getting better. So they consistently, everybody figured out how to follow a point across a room. And some of the kids figured out how to follow a shifting gaze. And they got better at requesting and asking for things. And this is very similar to cross-sectional data that other people have reported. On the other hand, this is overall rapport is the examiner rating at the end of the session, how hard did I have to work to keep this child engaged with me? So it's their subjective rating of I had to work. This might have looked like fun to you, but I was working really hard. versus this was, I could be relaxed and interact with this child. And again, the kids with ASD went down and are just starting to go up. So no wonder people are confused about what's happening early on. No wonder parents are confused. And if you map individual kids, it's not like they're all on the same month-to-month trajectory. Kasia Cherwaska at Yale with the Baby SIBS Consortium tried to also look at pathways from 18 months to 3 years, and she found 3 pathways, that 41%, 10%, and 6% are 3 pathways that described their sample of, I think, about 200 kids. But in fact, the reality is the sensitivity of those pathways, in those pathways, they were able to describe 57% of the sample. 43% of the sample didn't fit into those pathways. And then when they reran this with basically a statistical validation, it was less than half. So my point is there are lots of ways to get to autism, and things are changing a lot in that 15-month to 3-year period. They also had to leave out kids with atypical diagnoses, which is a problem because that's who we need the diagnostic instruments for. We don't need them so much when the child clearly has autism as much as when they don't. So what does this all mean? I think that it means that the trajectories across that first 2 to 3 years of life are quite different. It's not only that kids are different from each other, but that an individual child, you may have them getting better at following your point, but actually getting worse at wanting to come to you when you want to play with them. And it means that studies that have only a single time point are missing information, which is always true. But we have to be really careful when things are changing so much. It doesn't mean we can't diagnose kids. I mean, the reality is the clinicians and the ADOS were very good at diagnosing those persistent, severe kids. So about 1/3 of the sample, they were really right on. And the ADOS actually did quite well. But the clinicians giving the ADOS had a much harder time when they were just going with their best estimate. So we did that study in the middle of doing this other study, but the other study is trying to have multiple measures, so more than just an ADOS, parent reports and direct observations, a larger sample, and we have a more diverse population. So we started in North Carolina where we have rural families, we have a significant African American population, and we have more families with less education. And this is just to show you, we started at 2, saw the kids at 2, 3, 4, 5, and then 9. And this is where we were, starting with 200 kids. We had about 170 when they were 9 with complete data. And it just shows you race, gender, again, more boys than girls. Mean age when we met them was under 30 months. Mean age, that basically, although I'm calling this 9-year-old data, they're really 10 if they're in North Carolina and 8 in Chicago, which just had to do with funding. And then this is a much more intellectually impaired sample. And I think that's important as I talk about the results, because these are kids that 22 years ago, their families brought their 2-year-olds to get an assessment for autism. So these are also quite extraordinary families that they would do this, that they would say something's wrong when my child is so little and seek help. And they also had resources. And what's interesting about this sample is they're not mostly wealthy at all. They partly came from North Carolina, where Teach had a great network with primary providers and said, we can help you, and we provide free services. And then they came from Chicago, much more affluent group of families. But again, families who were on the ball or had a physician or somebody who said, look, we can get you help. But that's not a typical sample. And again, remember, the nonverbal IQs of the other sample were 80 and 94, and here we're talking about in the 70s mostly. So predictors of autism from 2 to 9, the clinical diagnosis, and this is pretty interesting, Because remember the data I just showed you with the clinicians, the clinical diagnosis was actually the best predictor from 2 to 9. And part of that is that, again, this sample is much more intellectually disabled, and partly it's a different thing doing a clinical diagnosis, even with a 28-month-old, than a 15-month-old. So by the end, there are big shifts in our ability to make diagnoses. And we're much better at 24 months than we are at 15, and we're better at 2.5. By 2.5, I think we're almost as good as we're going to get, because things get more complicated for the bright kids when they can talk a lot. Much to our surprise, repetitive behaviors at 2 really predicted outcome. A lot of people in those days when we started this, it was the era of theory of mind and everything is social and who cares if the child is stuck on, carrying a feather around. But in fact, kids who carried feathers around and also had other disabilities were much more likely to have autism than kids who just seemed socially withdrawn. Our observations of social behavior at 2, so on the ADAS, were also much more predictive than parent report of 2-year-olds. And part of that was that parent report, even in a long interview, the ADI is like 3 hours long, or two hours for a little kid. Parents who didn't have other kids often just didn't know. It didn't ever occur to them that other people's children do not wake up, sit in their crib, and wait for their parent to come in to see how they're doing. Or that other kids feed their parents because they want to get rid of those carrots. People just don't know if they haven't seen a lot of typical kids. On the other hand, parents' descriptions of how their children tried to communicate were quite good predictors. So asking parents specific questions about, does your child ever take your hand, lead you to a door, and put it on the doorknob and turn it, were actually quite predictive. Parents can answer lots of questions. They just don't make inferences. They don't know what inferences to make. And then again, much to our surprise, verbal IQ. Now think, what is a verbal IQ of a 2-year-old who can't talk? Was a very strong predictor of autism. And that's because the things in, like a Mullen, which is a test of early development, before kids can talk, are things like, does your child respond when you call their name? Do they come to you and try to vocalize? Do they vocalize back and forth to you? So they're actually almost definition. They almost define autism. And then here's the trajectories. This is up to age 14. And I don't know if it's coincidentally, but here we again had 4 trajectories. But what I want you to see is on the right, there are 2 trajectories, a very severe, which is on the bottom, so higher is worse, again using ADAS scores, and then above it is a less severe, but 80% of kids stayed in a pretty flat trajectory this is from age 2 to 14. So it's really quite different than the kids from 15 months to 3, where we had 20% in that severe group. Here we have 80% are not changing. Some of that is because these kids have more intellectual disability. Some of it is, we hope, that kids now are getting more intervention. But it's also the case that things are much more stable later on. And that, I think, is a real press for early intervention. I'm making a leap here, but I think it's a press where there are things that change early on that get more complicated, as I said, because options for learning things are getting narrower and narrower for a kid who doesn't pay attention. Once again, we did have a small group, and in this case, it's just about 10% of kids who are getting worse. Most of these kids did not have autism diagnoses at 2. So many of them are from our control group of kids with other developmental delays who begin to look more like autistic kids as they have other kinds of social deficits. And then we had a group of about 10% of kids who really got better, and I'm going to talk about them too. So let me just stop talking for a minute and just show you some examples. So this is a little boy at 4 who looked absolutely as autistic as a 2-year-old could. And then socially he got better, and you'll see in this video, he's with his mom, they're doing an ADOS. He has classically autistic language, but he does talk. You'll see his IQ scores, and let me just have you see what he does.
Blowing bubbles.
He said, she blowing bubbles. He blowing bubbles, actually. That's the examiner.
They go down here?
So she go down here.
Out.
Take it out.
It won't come out.
Let's have turn.
Okay. Let mommy hold them for you, okay?
He just said his name and have a turn.
The bubbles.
I think we need a little more bubbles.
Dip.
Okay, dip it in. Okay, good job. What are you doing here? Okay, ready? Let's try again slowly.
So he
Okay.
shows, he smiles at his mom, he looks at his mom,
Okay.
he does flap.
They go down here.
Yeah, get it. Hurry up. Oh,
And they go, it won't get out.
no, you can't get it out of there.
So he's a kid. Well, on the ADOS, he met criteria, but barely. On the ADI, based on his mom's description, he did sound quite autistic. He's got a very, very actively involved mom. Both parents, actually. So here he is at 9. He now has glasses, and we're going to ask him to teach us how to brush his teeth. Okay. And his mom is not supposed to talk in here, but
Yes.
you'll see.
Here's the hot water, here's the cold water, here's your toothbrush, and here's the
Yeah.
toothpaste. So
Here's
start
how
from
you
the
do it.
beginning, okay?
Well, you gotta start at the beginning.
Start at the beginning, what do you do?
So you're getting a Pokemon's over. Okay,
Yeah.
Pokemon's over. So what are you gonna do?
What's the first thing you do? Start from the beginning. What you doing?
Then I will wet my tooth on and then put some toothpaste on it.
I don't know what that is. That's the North Carolina way you brush your teeth, is you throw something over your shoulder.
And make sure you get those back ones.
His mom is not
Okay.
supposed to be coaching him, but
And then what are you doing? Oh, you're doing a wonderful job.
You're really getting all those teeth nice
Yeah.
and clean.
Wow.
Now it's all nice and clean.
Okay, and then what do
Then
you do after that?
Then we get, usually in the mornings, we get ready for
Well,
school.
what were you doing with the Dixie cup?
this is the disadvantage of parents seeing a lot of ADOSs. Is the mom's going to give him the ADOS for us. But what I wanted you to see here is his eye contact is terrible now. He has less facial expression. It's a little bit different of a situation, so I'm being slightly unfair. He has all this bilateral movement, which I think was always there, but we didn't see it before because he was just flapping here. He has a lot of language now, which is really nice to see. And you'll see his verbal IQ went up from 74 to 88, which is great. This is on a whisk. So this is not a cheap IQ. But socially, he's actually more obviously abnormal now at 9 than he was at 4. And then I just want you to see him here at 17. And look at his verbal IQ. It's so, oh no, this has got to.
What kind of plans you have for when you graduate from high school?
Well, I wish to go to School of Communication Arts to do digital audio. I want to do like digital audio recording.
And what is that involved? I don't really know.
Well,
much
it is. It's
about
like you record like a band's music. You know, you have different people working on the set. You have people that do the mixing.
that.
You also have people that operate the recording and mastering equipment. I want to go along those lines. You do the mixing or doing the mastering, like albums, you know, and stuff for bands. That'd be cool, you know.
So what would you need to do to be able to do that? What kind of training would you need to do?
I wouldn't need to go to School of Communication Arts to take their digital audio program. They have really nice, they have like several studios, or like small ones, or like maybe a room or two, you know, sort of small ones. I think there's like, I'm not sure, 3 or 4 studios. They've got like, or at least 3 or 4 setups. They've got, look, what they teach is Pro Tools, which is basically a hardware and software system for digital audio production.
So I'm going to stop it. But he is the sweetest person on earth. He did go to college. He did get a degree in digital audio, and he's still working in the digital audio program. He is a lovely person, good adaptive skills, can drive now. He has terrible eye contact. When you're talking to him, you really feel like, I just need to move my head over and catch him, and you can't. He has not a lot of facial expression, but a lot of good, well-intentioned statements. He has no friends. I mean, that's the hard thing. He has been sort of adopted by this group at the college in terms of inviting him to go places. He's very involved in church, but he's very socially isolated. And to us, he looks so nice, but he's not necessarily, I mean, he's 17 there, and in some ways he looks like he's 40. And he really cannot go through more than 2 or 3 sentences without talking about digital audio. Which is fine. I mean, and much better that than a million other things. And I don't think any of us would have guessed he would be like this from seeing him at 2 or 4 or 9. But there is a progression there in terms of social intentionality, which got better and better, even though some of the things got harder for him. So one of the things we saw, in those pictures of trajectories, was we did have a group who got a whole lot better. And when we look at them, in fact, this is verbal IQ of those same groups. The green are the kids who got better on the ADAS. And the ADAS controls for verbal IQ. So they were getting better not only in terms of their social skills, but their verbal IQ was shooting up. And this did start early, but it kept going. And I think that's an important thing to remember. So if you see a child with an IQ of 70 when they're 2 or 4 verbally, and a nonverbal IQ of 80, this does not mean they'll stay there. And we can have a lot of hope that many of those kids will get up even higher. But you can also see that in terms of verbal skills, many of the kids stayed very low. This is from VINELAND Communication Ages, so it's not IQ, it's not comparing you to other kids, it's just looking at ages. And if you realize that blue line, which is 30% of our sample, are basically never getting up to a 2-year-old level. So there are many people with ASD, and again, this was more true 20 years ago, partly because we didn't see as many high-functioning kids, and perhaps we're doing a bit better, but there still is a substantial proportion of kids where language development is very slow. We did have 2 groups, and there is a group that they're the ones right in the middle, so the dotted red line, and then there's kind of a brown line that truly didn't have a linear progression. They started out slow, and then eventually moved to almost catch up. And those kids at the very top end, this is not a 1-for-1 scale, are really at age level, the very highest level people, like this young man. But what's important here is we didn't see rapid gains. The rapid gains tended to start at 2, and a few kids at 3, and if they hadn't started after that, in this sample, they did not happen. Didn't mean they didn't make gains, but they didn't move up to fluent speech. So it's very early on that you begin to see that trajectory. But it can continue. It doesn't mean that it's done at 3. It just means that something's got to click. We did have, and this is at 9, and I need to just compute this now, I just haven't done it. About 40% of both the Chicago and North Carolina samples really did have fluent language. So that was higher than we thought in those days. And again, remember that this is a sample whose mean IQ at 9 was about 65 to 70. Only 14% really didn't have consistent words. So it's not that most people are nonverbal completely. And again, I think stats would be even better today for people identified today as 2 and going forward. But there's still a lot of people with autism who have very significant language impairments. And if you can only speak in simple sentences and only use, say, 10 different verbs like want, have, put, you are restricted in what you can do. So in our last analyses, we've been trying to make sense of how do we describe what happens to these young people now that they're 19 or 21 or 22. And we turned out we really had to have a bimodal distribution, which is people with IQs that are close to average versus other people because their lives are so different. So we ended up grouping people at a cutoff of about 70 for a nonverbal IQ, just because generally their nonverbal IQs of the less able people are higher. And then we also pulled out a group of people, because we have 8 all young men who really don't seem to have autism anymore, who on the ADOS, ADI, any kind of measure really seem out of the spectrum. And so we are calling them very positive outcome. So if you look just at maybe the top numbers here, you'll see the mean IQ of under 70, verbal IQ was 22, and nonverbal IQ was 34. So this is a very split distribution. There's not a lot of people hovering in the middle. And the more able group, they were actually close to average. So again, it's not at all a normal distribution. And the people who have lower IQs have more of every kind of problem. And then let me show you just quickly, because I feel like you'll, again, remember this. This is a little boy who was one of the most autistic 19-month-olds I have ever seen. And this is him with his grandmother. And Pam, the examiner, is going to try to get him to look across the room at a mechanical bunny.
Quinn, look! Look, the Quinn! Hey, the Quinn! Look! Look at that bunny! Look at that! Look!
So he can attend, but he was getting up to go away. He was like, this is a little bit much.
Here he is.
Here comes the bunny.
What do you say?
And I think he's trying to make it go, actually. I mean, I don't know, but he's, and then he does look at her for 1 second. Okay, so here he is at 9, actually I think about 10, and he's been in a teach classroom in North Carolina. He's had a lot of help. He lives with his grandparents. His mom lives down the street with his brothers and sisters, so he sees her a lot. His grandparents, all of them, are totally devoted to him. And he's had some really good teaching, and we're just doing the same task. This time we're pointing out a remote control car instead of a bunny.
Oh,
Oh, wait.
What do you want?
Oh, I'm sorry. They're blowing bubbles.
I.
With Bumblebee.
All right. Good talking, Winnie. Good talking.
So I put the wrong video in here, but he actually does follow a point now. In fact, he follows the shift in gaze right away. He talks in that I want, but bubbles please, but he is very socially directed. He's got a lot of movements, doesn't know what to do in more complicated things, but for going from that kid who would walk over you, he is a different kid. And here he is at 20. At 20, he was living with his grandparents. He had a job at a bakery within walking distance of their house. He is like their butler. He is really clean, and if you sit in the living room and put a glass down, it's gone and in the dishwasher before you know it. But he is very proud of what he can do. He really helps out his grandparents. He took us in his room, showed us his lineup of videotapes. This is a little while ago, but all alphabetized. But he was not upset about us wanting to see them, let us take them out of the alphabet, put them back. But and really, I think adaptively is doing well. You'll see this is our attempt to have something sort of like the bubbles. It's a little more age appropriate. Doesn't quite work, and you can see by the expression on his face, he's wondering what has come over Whitney.
You like it?
Like it. Now he talks less. That's the one.
Oh, should we do it again?
He can talk, but he could go hours without
Ready?
talking.
Set,
Go.
go! Oh, here we go. Oh, that one went really far. We'll put it right in there. Okay. Oh, you want to pull it? Okay, pull it. Pull it hard. Oh, look, Quinn.
Okay.
Look at that. Yeah.
So we're actually trying to have things be a little weird just to see how he reacts. And he is really pretty appropriate given that this woman is shooting things all around the room. He, again, I think socially he has switched so that he's someone who watches faces actually much better than the first boy that you saw. But he doesn't use his language. I mean, that is just not something that's come easily for him. He has some repetitive behaviors, but they're very minor, and in the long run, they've actually helped because he is so neat, and he wants things to be neat, and he gets mildly upset if something's out of order, but he does not have temper tantrums or aggressive behavior. And I think our biggest worry is what will happen to him as his grandparents age. How do we make sure that he has a good place to live and is safe and can do the things that he's capable of doing? So I just put this slide up to remind you what the trajectories look like with verbal IQ. This is the trajectory, and we've flipped it again so that going up here is better on the ADI social descriptions of social behavior. And what I want you to see here is that actually everyone is getting better. And even the kids, the lower graph is the kids with less language, those kids with IQs at average of about 35. They're still getting better. They are acquiring social skills. And then we've separated out, the highest line is those 8 guys who had a very positive outcome. And the second line is the other 24 who have equal IQs, so IQs of 100, but still have autism. And you can see that they're beginning to separate out in terms of social behavior, even at around 6 to 8 years of age, so that trajectory. But it's later than the trajectory of language. And I think this is important for parents because parents get so focused on my child is going to be normal, by the time they're 4 or 5 and their language is coming, so why aren't they normal? And what we can say is here's a group of people who did very, very well, but we're making still subtle improvements in social skills all the way up to teenage years. Adaptive skills, we see the same kind of split, although the curves are different. And the 24 in the middle are these high IQ, but still autistic people who are much less independent. And again, it's a little circular because we've pulled out those high 8. But the other thing I think which is important, this is a adaptive score compared to other kids. So the less able kids are not losing skills, they're just not keeping up when they're little, but they're getting better as they move into young adulthood. I don't think they're going to catch up, but it's not that they can't learn anything. Factors that didn't predict outcome in terms of diagnosis or comorbidity were race. We have no race effects. Puberty, we had poor families doing Tanner scales. Any of you have ever done those? Every 4 months, they were checking their kids' armpits and genitals and making a list for us. That's the level we had it, and it didn't predict anything besides age. Adolescent onset of seizures, we have about 25% of the sample who have had their first grand mal seizure in adolescence or young adulthood. But we don't see anything in terms of premorbid, like getting irritable and then having the seizure, or changes in behavior afterwards. And we have a very small group of girls, especially when you start dividing up by IQ. So the only place we've got sex differences, and I don't know if you can see this, there's a very faint line which is dotted, which is males, and the females are the dark line. And what we see is that the females are getting more anxious as they get older into teens, whereas the males, it's either a smaller change or more subtle. So there's crossover effects on both the ACEBA anxiety and depression scale for the girls versus the boys. Actually, and that's true both for kids. It's more true for the kids with ASD, but on the right are kids who didn't have ASD in this sample. So they were kids someone at some point thought might. Let me just finish off. I want to talk just briefly about what seemed to pull out these very positive outcome kids. And you can see there are two columns, more able but not very positive and very positive. And this is basically just defining the sample. The kids with the very positive outcomes have fewer comorbidities. They're less likely to have depressive symptoms, irritability, or hyperactivity. Again, this could be circular. But when we look at the difference between these kids at age 2, the very positive outcome versus equal high IQs, but not so, still clearly autistic, the differences are in repetitive behaviors. Between 2 and 3, the kids who had the best outcome decreased in repetitive behaviors, whereas everybody else went up slightly. Hyperactivity, which probably wouldn't surprise anybody, but this is just a general rating of hyperactivity at age 3, was more likely to occur in the more able people who continued to have autism than the other group. And then parents' involvement. This is more than 20 hours in 6 months. This is not in a week. So basically, parents who got their child to some kind of treatment more than 20 hours in a 6-month period after they were diagnosed, those kids seem to do better. Now, the reality is the less able kids all got treatment. So this is a difference that we only see in the more able kids, and we can't say that the treatment made them better. But what we wonder is if parents took on this diagnosis and sought out treatment and stuck with it, whether that's where the effect is coming from. And that's where I'm saying, again, we can't say conclusively anything. So let me just conclude by saying, what did we learn from this? I think we do know, even in this sample, which is less able than kids we would see today if we took 200 consecutive referrals, more of them have complex language and more of them have some language than we expected. And a substantial number of them have IQs and even language IQs, verbal IQs in the average range. In this sample, autism could be diagnosed as young as age 2 and was generally very stable from age 3 on. But we do have some kids who very steadily make quite remarkable progress. Verbal IQs improved from 3 to 9 and actually even into 14. Changes in social behavior and adaptive behavior also improved, but they were much more subtle and slow and into the teens. And repetitive behaviors had a much bigger effect than we expected. The trouble is we don't know quite what to do about it. I don't think it means that you should be stopping a 2-year-old from flapping. That's not the implication, but that probably is a marker for something. So can we do the things that we thought? Well, I think we can predict what's ahead. I mean, again, the sample now, who we see now is different, so we've got to constantly remind us that. But we do have very clear trajectories for a substantial proportion of kids. Can we select targets for intervention? Well, I think we can, but again, this needs to be tested in more direct fashion. We do need to worry about, for example, very active, bright kids. What are they doing and what's happening with them? We do need to think about adaptive skills and remember that they can keep improving. And we do need to be more patient, I think, with changes in social behavior. I think we need to remember that different dimensions in a disorder like autism that's defined by multiple dimensions often have different trajectories, that there is an undeniable effect of IQ, language level, repetitive behaviors, and parent involvement, I think. And that IQ and language improvements are necessary but not sufficient to guarantee positive outcomes. So we want those to happen, but it doesn't mean that every smart verbal kid is going to be completely independent. On the other hand, there are clear changes and improvements for many kids into adulthood, and we actually just got funded to continue for the next 5 years, so we'll get to see these kids into their mid-20s. I think in our study, and there's a number of other findings similar to what I showed you, that parent involvement in some kind of training, even if it's 6 months, 20 hours, is linked or at least associated with gains, particularly in the higher functioning kids, but also actually in adaptive skills for the less able kids. But we can't say that the intervention made the difference, but somehow supporting the family. So I'm just going to end with, this is a positive note. I think we'd like to know, how do we use the strengths of kids? This guy has a sense of...
So, have you seen any good movies lately? Any comedy movies?
I saw School of Rock.
Oh, really?
Mm-hmm. That was okay.
Did you, do you have, The Spy That Shagged Me? Do you have that video?
I don't. I only have the
I
original.
shall call him Mini-Me. Breathtaking.
That's a very good
Dr.
impression.
Evil.
Yes. Is that the one where he does the rap song?
But throw me a frickin' bone here, Scott.
Is that the one where he's trying to get therapy for his father-son
Exactly.
relationship?
Right.
Uh-huh. That's a funny one.
You're not quite evil enough.
Yes, I like Austin Powers.
Smashing baby.
Now, he could go on for hours, but I think he's a young man who's got his strength, and he has this very particular kind of intonation, and he figured out he is ideal for doing these imitations. And so I think we would like to figure out better, how do strengths beyond IQ help us, and how can we foster those and help families support them. I think we're also interested in pathways of comorbidity and the kinds of things that the other speakers have talked about that we can treat. We can treat aggression. We can treat many of the behaviors that are difficult. And can we help families do a better job on that? Also anxiety and depressive symptoms. So I think at that note, I'll say millions of people have been involved in this, and I think I have pictures. Oh yeah. Anyway, thank you very much.